Hi, everybody. This is Dr. Leslie Blevins with Enilda Clinic at enildaclinic.com. Thanks for joining us. Today, we have Ben Kennert. He is a licensed psychologist and a board-certified behavior analyst. Dr. Kennert is actually one of my friends from internship, and we met over in Nebraska. That's where we did our internship together. So thank you for being here today, Dr. Kennert. I really appreciate it. Ben is, or Dr. Ben, that's what he goes by. Dr. Ben currently provides services through a small private practice in Southeast Michigan. He works with primarily children, adolescents, and families to overcome challenges by building a bridge from where they are at to where they want to be. This bridge is constructed by learning new skills, practicing those skills, working to address needs in the home, school, and community context, and gaining insight that leads to challenges in behavior, including patterns of thinking and feeling. Dr. Ben feels that a strong therapeutic relationship with clients and families is essential to maximize outcomes and often takes a fun, humorous, lighthearted approach within sessions. Although he is often tackling serious and difficult issues with clients, Dr. Ben has learned that compassion and humor often go hand in hand. He received his BS degree in psychology from Western Michigan University and his master's and doctorate degrees in school psychology from Central Michigan University. He completed his pre-doctoral internship in behavioral pediatrics and integrated primary care at the Monroe-Meyer Institute for Genetics and Rehabilitation at the University of Nebraska Medical Center in Omaha, Nebraska. He has had experience in training within a variety of settings, including hospitals, primary care, applied behavior analysis, treatment centers, private practice, schools, and in home-based and community-based treatment. Dr. Ben has instructed undergraduate level classes in developmental psychology at Central Michigan University and has presented or published literature on topics including pediatric sleep, special education, cognitive and emotional self-regulation, behavioral intervention, suicide prevention, and charged syndrome, a somewhat rare genetic syndrome impacting multiple sensory areas of functioning. He's interested in research on the application of behavior analytic treatment strategies to problems that have been classically considered mental health or medical in nature. All of that's so important because it is, because you know your stuff, and that's why I have you here today. I'm so excited that you're here and giving us your time.
Thank you.
Yeah.
I try my best, and thanks for having me.
Yeah, super excited. So today's conversation is specifically going to focus on clinical behavior analysis. I feel like we could jump into so many different topics with you, but that's the topic for today. So Ben, could you give us an overview of what clinical behavior analysis is?
Yes, so I can talk to what clinical behavior analysis is kind of defined as generally, and then I can talk a little bit about what my approach to clinical behavior analysis looks like. So generally, when we are talking about clinical behavior analysis, really all we mean is applying behavioral science, basic behavioral science, to problems that have historically been thought of as mental health in nature and outside of the scope of typical behavior analysis services. So that can be things like depression, anxiety, grief, coping, interpersonal relationship challenges, anger. It can be a great many things. And so a little bit about what my approach kind of looks like is I use a combination of many different strategies, including acceptance and commitment therapy, or ACT, what's called functional analytic psychotherapy, and a variety of other strategies, including behavioral consultation, family training, and motivational interviewing, behavioral skills training, a lot of different things that kind of go together. And and are individualized to the person that I'm working with. And it all kind of starts with the person that I'm working with, the client, identifying what their values are. What are the things that are really important down to their core? One of my core beliefs working with anybody is that everyone has values, whether they feel like they're currently connected to their values or living according to their values or not. I think that everyone has a core value system, and it kind of serves as our guiding, it's sort of our GPS for our decision making and living our life according to the way we want to live it. And so another one of my assumptions when I work with people is that when we make decisions throughout our day, when we choose these behaviors all day long, and we're making choices that are away from the values that are really important down to our core, we're not doing that because we don't care about those values or because we just don't care. We're doing it because there's some kind of a barrier that's getting in our way, whether it's a skill that we don't quite have or need a little bit more practice with, or there's something going on in our environment around us that we need to identify and figure out how to work through or work around. And so the approach I take to clinical behavior analysis is very individualized, and it starts with the person I'm working with defining, what do I care about?
Yeah, I just love it so much. I love that we're getting to have this conversation. You're the first person I'm interviewing who I feel like does the same exact thing that I do, which makes sense. I mean, we were in the same internship program, so we have, I think the end part of our training was pretty similar. We were at different sites, but pretty similar. So yeah, and we're both psychologists, we're both BCBAs, and so, but I'm just so excited to talk about everything that you're going to say. I love it. I love all of it. Yeah, and especially the ACT part. I'm sorry.
I think that my internship year in Nebraska, where I met you, that was a really core piece of my learning and kind of figuring out what my approach was going to be. And as you probably know, figuring out how you're going to work with clients and how you're going to achieve your own values is kind of like a puzzle, right? Mm-hmm. It's not something that you really start off knowing. You have to sort of take pieces here and there and sort of put together your thing. And so you might work with this supervisor and they do something you really like, so you're going to take that piece, right? And then you worked at this place that offered this really wonderful service, and I want to take a little bit of that with me. And maybe you worked with a colleague who had an idea about something. Wow, that really stuck with me. And you end up with this sort of puzzle that's put together to form your approach. And I think it's always kind of evolving and changing.
And to speak to that, I feel like especially with ACT, I specifically do ACT, and I want to ask you a little bit more about the behavior analytic psychotherapy piece, because I haven't studied that one directly. But for ACT, I feel like that one is one where to really do that therapy well, you have to live it. You can't just talk about it with clients. And exactly what you're saying, it's an experience that informs your values. And so they're evolving as you're growing and aging. And so exactly what you just said, you're picking all these pieces together to form who you are as a human. And I think for us as clinicians, that informs a value set that helps us to deliver what each of us feels is the very best services possible for our clients. And at least for me, that's why I love ACT, because I feel like I get to be who I genuinely am, and I get to help each of my clients be who they genuinely want to be. Love it.
Totally. Yeah, absolutely. I love it, and it took me a while to really get it. Mm-hmm. And once I did, I started to realize that there's a lot of real life application for me in here. Mm-hmm. And it's funny that you say that, because one of the big components of ACT is, of course, mindfulness, which here in Western medicine, we're a little behind the curve compared to Eastern medicine on mindfulness. And we're starting to catch up a little bit and recognize how valuable that is. And I've been really excited lately to see mindfulness starting to take off in the schools even. In the area in which I work, I've started to meet a couple school-based mindfulness experts. So cool. I'd never heard of that position, 5 years ago even.
Yeah.
And so, yeah, there's a lot to ACT that I think is valuable in just kind of living your own life. I don't know if you've had this experience with when you're working with a client and you have a bit of a breakthrough with a client, and then after the session, you're kind of reflecting on that breakthrough, and you go, you know what? That's something I should apply to my own life too.
Mm-hmm. Yeah.
I've had that many times where I've gone, oh wow, I should take my own advice here.
Oh yeah. Oh yeah.
Because of course we study all this stuff, right? And we're around it all the time, but we're also human and we behave just like everybody else does. And so I tell my clients all the time, I also have kids. I have a 10-year-old son and a 4-year-old daughter. And I say, and I'm married as well, and I say I go home and I screw up just like everybody else. And I sometimes feed my kids junk food, and I sometimes let them watch too much electronics. And I miss my exercise pretty often. It's all just kind of figuring out life and how to live this thing that we're all part of.
Right, exactly. Okay, before we dive in too deeply, I want us to kind of focus on the ethical side of clinical behavior analysis. I know with more traditional applied behavior analysis, we've really been having this revolution that has been much needed on the ethics side with adult autistics really expressing the trauma they experienced in the past, and maybe even some still today, unfortunately, within ABA, and treatments that have been forced upon them that were pretty rigid and just not in their best interest. I'm wondering about clinical behavior analysis because it's a pretty different type of treatment. Can you help me understand how that might fit in with the ethics that is in the conversations we're having today with families?
Absolutely, and that's a much needed move forward, right? I think that so autistics who have gone through the ABA process in the past and have had a traumatic or negative experience from it, I think it's really valuable that you share your stories and that you help this world to evolve and move forward in a way that's much more beneficial to you, and that's really tough to part of a diagnosis of autism at a young age is difficulty expressing and communicating, and so of course some of the kids that are involved in the ABA world don't have a voice for themselves, so it's really important that they have a voice through you who've gone through the experience. And so if any of older adolescent adult autistics are watching this, keep speaking up. That's extremely valuable. I will say clinical behavior analysis can be differentiated from ABA in a lot of ways, and clinical behavior analysis is truly a talk therapy. It's different from applied behavior analysis in the sense that we're with clients in a room and we're primarily creating behavior change through vocal behavior, through conversation. And some of the concerns that I've heard from adult autistics who've gone through the ABA process was being made to do things that they didn't want to do, or not feeling like they're heard completely, or feeling like they were engaging in behaviors that for them were adaptive, right? For example, self-stim behaviors to decrease anxiety, and being made to decrease those behaviors that had a real true adaptive function for you. Those are problems, right? There's nothing in the clinical behavior analysis relationship that's going to result in you being made to do anything that you don't want to do. And as a reminder, we kind of go back to this all starts with your values. If you were to come in and see me, or see somebody else providing this service, it all kind of starts with building a relationship with your therapist And I tell my clients all the time that if you don't like coming to therapy and you're finding it's a huge drag, or you feel like I'm doing something that's uncomfortable to you, that's on me. That's a problem, right? And I want to know about it, because if I don't know if I've done something to make you uncomfortable, I can't get better. I can't fix it. So really, to create behavior change through a talk therapy relationship, that there's a couple things that, in terms of the relationship in and of itself, are really important. And one is that we have very open communication, and I hear everything that you're saying. If you don't feel like you're listened to, then how am I ever going to hear you, right? And how am I ever going to help you? And so, so that's a couple things that I'll say about that.
Yeah, I just really love how you went through the really distinct behavior change process between ABA and clinical behavior analysis. And I know in my own experience with ACT that it's about sort of it's about increasing psychological flexibility. And so it's about the individual client taking perspective, and flexibility in and of itself can be more or less in any situation, depending on if that's adaptive for that person or not. In some situations, we need to be rigid, like with setting boundaries, right? Sometimes it's going to be more adaptive to be rigid with your boundaries than to be more flexible with your boundaries. And so I think even in that sense of having psychological flexibility, and there is no one goal, just like what you were saying. And so it's a totally different goal, a totally different set of skills that you're utilizing with the client, or that you're even teaching the client to utilize with themselves, so that they can have a more adaptive and happy life. So yeah.
Absolutely. And a clinical behavior analysis approach is not it's not designed to be an autism specific approach. It's for everybody, right? It's for anybody who feels that they're not living their life 100% according to their values, which is every single one of us, right? Every single one of us has things that we could be better with and do better with, and 99% of those things are invisible to everybody else. Mm-hmm. And so, traditionally applied behavior analysis only focuses on overt behaviors that you can see, mm-hmm. where there's a lot of limitations to that. And clinical behavior analysis is an attempt to bring some of that science to some of those behaviors that maybe aren't as easy to observe to the eye, or also considering thinking and feeling as part of that behavioral class as well.
Yeah, I love that, because it's thinking and feeling, for many people, if you think about anxiety or depression, grief, like those are concerns that come up all the time that won't necessarily be obvious to an outside observer, but the symptoms are so real to that individual person, the thoughts and the feelings, that they are tremendous for that person and for their quality of life. So, okay, so now let's dive a little bit deeper into clinical behavior analysis. You've mentioned a few different types of therapies. I've talked about ACT a lot on my learning videos. And I just mentioned that the goal of that one is psychological flexibility, so that you can move closer to your values. I really want you to tell me about functional analytic psychotherapy.
Okay, sure. So functional analytic psychotherapy, to my knowledge, is a pretty recent application of clinical behavior analysis, and so one of the core goals of functional analytic psychotherapy is paying more attention to the behavior that's happening right there in the session, right there in the treatment room. And one of the assumptions that's sort of perpetuated by therapy at times, and by problems that are sort of seen as internal or seen as interpersonal. So, within families and relationships, it can be assumed that those behaviors aren't going to occur in the presence of a therapist and in the context of sitting in an office together. And that actually is an erroneous belief, because most of what we see in terms of problematic, if somebody's anxious, if somebody's tends toward anger, if somebody has interpersonal relationship difficulties, you're going to be able to see that in the therapy session as well. And it requires paying some more attention to the behaviors that are occurring right there in the session room with you, and intervening on those behaviors more directly, and intervening on those behaviors in a way that we are providing reinforcement in through the way that we give our attention and give our praise and appreciation for certain types of behavior and change in a way that helps move that client forward. So I'll dive into that kind of in a little bit more detail, but just to give an example of what some of these behaviors might look like. So, if you're in a therapy session, some of the target behaviors that you might be able to see right there in that room, and we can create that problem and work through it together. If you have difficulty tracking your own behavior, that can be a target. If you have difficulty expressing your needs in an assertive way, expressing needs in a subtle or a more indirect way, pushing other people away with inappropriate social interactions, kind of pushing people away from you through your own behavior and how you act or present yourself. If you tend to be somebody who gives a little bit more than you get back, I hear that from a lot of clients, feeling like other people aren't really giving me what I put forth in relationships. And why is that the case? Difficulty asking for help and accepting help. It can be being too demanding or aggressive when trying to get needs met. It can be difficulty tolerating delays or denials or disappointments. Perfectionism difficulties come to mind. It's really difficult to tolerate failure and disappointment. These are skills. These are behavioral skills that we can work on and build those repertoires, so that when we build those repertoires within a session, we can start to generalize those things outside of the therapy session as well. With functional analytic psychotherapy, there's 5 steps really. The first step is to define and notice what the target behaviors are that are related to whatever problems are being presented in the therapy session. And you do that together as a partnership. So the therapist and client, we're working together to figure out what are the behaviors that we're targeting here? What are the skills involved? And we work on noticing when it's happening, first off. Second is, let's try to evoke, let's create a situation where that problem is going to present itself so that we can work through it. So we're going to evoke that problem behavior. And when I say evoke the problem behavior, it's creating a situation where we're likely to see that discomfort. If I notice a change in behavior from the client, if somebody who's usually very outgoing is suddenly not so much, or if I see some of those shy, withdrawn sort of behaviors, or if I see somebody who's usually very reasonable and very logical suddenly getting angry about something, it lets me know that we've approached a skill deficit, and that our behavior is accommodating for those deficits. After we notice the behavior, we evoke it, then we're looking for replacement behaviors that can serve that same purpose. One of our core beliefs in clinical behavior analysis, any contextual approach, is contextual being behavior as a part of the context of the environment, is that every behavior serves a purpose. Every behavior does something for us. And there's other behaviors that might lead to a more consistent life with our values that'll produce that same reinforcement, that same function for us. And our goal is to start replacing those behaviors with something that's going to help you live a life more consistent with your values. After we notice, evoke, and reinforce those replacement behaviors, we're analyzing the outcome of that. How did that go? Did you find that to be helpful? What do you hope would have went different? What came up for you when we did that practice? And then generalizing those positive results to other situations. And part of the generalization comes from doing homework outside the sessions and figuring out who some of your close relationships are who can help support you outside of sessions to help recognize when you're engaging in those potentially problematic behaviors and helping you to work through using more positive skills. Remember, I work primarily with children and teens. So one of the first allies I look for is the parents. And parents are heavily involved throughout the therapeutic relationship with me. And they're checking in every single session with me.
You know, it's so interesting because as you talk through this, I feel like, wow, the client must need to be really smart to go through. And maybe it's because you're so smart, and I'm just like, oh, this is a lot. But I'm betting it's because the client is actively like engaging in it. Do they have to know the steps?
Not necessarily.
Okay.
So you're talking about, so for a younger child or someone who's limited verbal, can they participate in this type of approach as well?
Right.
And they can, because anything that's a behavior we can work with. If it's a behavior and it's a skill that needs to be improved, we can work with it. And when I'm talking about behavior, I'm talking about a radical behavior approach, where we're talking about actually thoughts and feelings are counted as behavior as well. We look at those the same way. Right. And if we can, if it's something that we can see during the session, it's something that we can change during the session as well.
Okay. Do you tell the client that we're gonna pretend that, the bully, I'm gonna pretend to be the bully, and I'm gonna say the things that the bully said to you last week, like, for instance, is it kind of pretend in order to help the client reimagine those experiences and those feelings and the maybe the more maladaptive skills that they start with? Or do you kind of try to do it in a more naturalistic way?
Totally. No, I'm very forward with my clients about what I'm seeing and what I think that we should do. And I'm always looking for client permission to move forward with things. And if a client's really resistant, which happens with a lot of the things that we work with, right? If you have an anxious client, you have to confront anxiety in order to work through it. And confronting anxiety is never the most pleasant experience, right? And so I'm just honest with clients about that. For kids, I would say that in a language that they understand. I often talk about anxiety as an example. I talk about anxiety as the anxiety monster. I like to give anxiety a little bit of a character. And okay, well, if anxiety is a monster and we want to fight against the monster, what are things that we need in order to fight against anxiety? Mm-hmm. If you were a monster slayer, what would you need in order to accomplish the job?
Mm-hmm. Yeah.
You would need weapons, right? You would need armor. I've had kids say superpowers, mm-hmm. Which would, of course, help us defeat an anxiety monster if we had superpowers. Other people to help, right? And so we kind of talk about that through that context. So, okay, so we need weapons. So we need, our weapons are our coping skills, our ability to work through things when things are hard. Our armor is our practice. Every time we practice, we build up a little bit more armor so that this gets easier and easier every time. Mm-hmm. The other knights and superheroes and, the rest of our team, they're the people who are going to help us through this process, like me and your parents. And who else is on your team? Who else is going to help you fight the anxiety monster? And of course, anxiety monsters are invisible, right? We can't see them. So one of the most important things that we need to be able to do on the front end is we have to be able to see the anxiety monster. And that goes back to that notice step. We have to notice when anxiety is poking its head out of its cave, right? When's that monster coming out?
Right. I wonder, going back to the noticing, do clients need, children or adults, do they need to be at a point where they're willing to accept, if they notice the thing that you're noticing as the clinician, do they need to accept that that's a problem? Because sometimes I have parents who want their children to come to therapy, but the child doesn't want to come to therapy. I'm thinking
That's
about
interesting. I don't think that I would move forward with practice for the anxiety, for example, until the kid is on board with identifying it as a problem too.
Yeah.
And so there's a number of things that I might kind of talk out with the kid ahead of time. One of the things I often see is like therapy session number 1. Kid comes into the office and their arms crossed and they don't want to talk to a therapist, and sometimes they even feel like they're in trouble.
Yeah.
And I just call that out when I see it, because remember that, if we're taking a contextual behavioral approach to what's going on, this is behavior too.
Mm-hmm.
And refusal is behavior, and saying no, that's not a problem, is behavior. It's all behavior. And what purpose is it serving for that kid?
Mm-hmm.
Do they feel like they're in trouble? Do they feel like I'm going to punish if they say a certain thing? Or kids going to tell me what they think I want to hear just because I'm going to give some reinforcement for that, right? And so one of the things that's important to me is to just be really open and honest about that, and call it out when I see it. So I'm often, the first session with kids, I'm going, it looks like you don't really want to be here today. Can you tell me about that? Is it super weird to just talk to a complete and total stranger about your personal life?
Mm-hmm.
I wonder why that's so weird, right? No, it's super awkward, right? I'm a weirdo. This whole thing is weird. And what I find is when I do that, it lightens the mood a little bit.
Mm-hmm.
And the kid has communicated what they needed to communicate with me.
Mm-hmm.
So they no longer feel the need to do it with their behavior, right?
Right.
If I don't acknowledge that they don't want to be there and that they think this whole thing is weird,
Mm-hmm.
they're going to continue to try to communicate that to me with their behavior. And we're going to go the whole session with arms crossed and not speaking, right?
Mm-hmm.
And that's a kid, the kid with their arms crossed and refusing, that's a kid who's not really ready to work on, addressing anxiety yet. They're not quite there yet. And so that's where I maybe would back up to some of our ACT strategies, some of our acceptance and commitment therapy type strategies, where we're practicing some mindfulness, and we're identifying what some of that kid's values are. What do you care about? What's important to you? You like Power Rangers. What is it about Power Rangers you like? If you could be a Power Ranger, what would you want to do?
Yeah.
Trying to figure out, what do you care about? What's important to you? Who do you admire? And that's identifying what are your reinforcers, right? What are the things that make you tick and get you to do the things that you do? And once we get to that point, we're starting to build that relationship, and we're getting to a place where we're gonna be closer to starting to target some of that hard stuff.
Yeah. So I think that how you're describing how you work with children. So I just to kind of preface this, I don't do talk therapy with older children. I only work with very young children. So I'm always working with the parents.
Totally. Yeah.
I just never do. It's not my cup of tea. But I love hearing how you do this, especially in the context of a law we have in Washington. So children 13 or older have the right to consent to therapy, which also means that they have the right to not give consent to therapy. Well, we recently updated this law, and parents can make their children go to therapy now for a short duration. And after that short duration, the child can then refuse therapy, but the parent can then switch them over to a different therapist. Essentially, the law is saying, okay, rapport was not built with that therapist, so you can try a different therapist, and that process can continue on and on forever and ever until the kid is. And so the thing that I find interesting is that what you're focused on in that context, if a kid comes in and it's kind of clear that they're not really consenting just yet to therapy, they're being pretty obstinate to starting, you're viewing it more as they're expressing an emotional need, and you're being very open and using their body language to help them express that need clearly. And it sounds like in the vast majority of cases, you can do that with success, and then the child is like willing and able to receive support in therapy. And I think that's important for parents to understand.
Yes, I think that if we take feelings and we take thoughts and we take everything that we're seeing the child do as behavior, all of it, the same principles of behavior apply to those things. If we see a behavior happening, it's because it serves a purpose and there's reinforcing value to it. So what are they doing it for? And is it something that we can work through and get past, right? Yeah. Maybe the parent is coming in because this child's very anxious. Maybe the child is very anxious. Maybe the child even recognizes that they're very anxious, but this whole situation's just really weird, right? And so anxiety-related behaviors are target behaviors that we can work on during sessions, right? We can work on avoidance. We can work on, quieting down or shutting down when something's scary. We can work on how to cope and how to problem solve through anxiety situations. Yeah. But also, those initial behaviors are target behaviors as well, right? And if we think, if we think in kind of a hierarchical fashion, it makes more sense for us to start working on the target behaviors that are lower down in the chain, right? The easier stuff first, so that we can have some success and build some momentum before we take on the stuff that's going to be really hard. Usually what kids are coming in for therapy for, what parents are bringing their kids to therapy for, is the hard thing. And that doesn't necessarily mean that it's the first thing that's worth addressing.
Right. Yeah. It's just like every other developmental skill. There's so many layers that have to be put in place if we're going to be successful.
Totally. And I think that too. So I don't make kids do anything. I don't make any clients do anything that they don't want to do. Right. And one, I don't personally feel that that's the right way to go about things. Right. And you mentioned earlier the concerns about potentially the ethics of that. I don't ever want a kid to grow up and say that Dr. Ben was such a jerk. They made me do things I didn't want to do. Right. And I don't want to be that person, right? But also, if I look at the theoretical orientation as well, a behavior that accesses reinforcement that the child selects to do themselves is going to have much more maintenance than a skill that they've been made to do for aversive control, right? If I can get a child by working with them and building that relationship and creating the context for appropriate behavior, if I can get them to select behaviors and it produces reinforcement for them and makes their life better, that behavior is going to last. And the same can't be said about, if a child's made to do something that they don't want to do during a session.
Yeah, I've always thought, not always, but since I've learned, applied behavior analysis, and especially ACT itself, I've always felt like, to me, it just feels like the most ethical way of living, because it's all about maximizing reinforcement for yourself and for your loved ones. And it's always about finding the positive and reducing punishment, of course. And so I just feel like, yeah, of course, that's, as clinicians, that's what we want. We want to increase reinforcement and do it in ways that give people more adaptive lives and everything. So, yeah.
Yeah, I borrow a little bit from the motivational interviewing set of techniques in that way. One of the techniques of motivational interviewing is just rolling with refusal. If you encounter refusal, don't force through it, just bounce off it and roll with it.
Yep. Yep. I have found that motivational interviewing is one of the strategies that physicians are taught a lot. That seems to be the primary strategy that they're taught.
Okay. That makes a lot of sense. That's really cool. I didn't know that.
Yeah. Will you go into what motivational interviewing is?
Sure. Yeah. From my understanding of motivational interviewing, it's basically, so I'll talk about what I understand it to be, and then I'll talk about what I actually kind of borrow from that world in my approach. So what I understand motivational interviewing to be is that we're looking for clients to engage in positive change language. So during a talk therapy session, the client's doing a lot of talking during the session, right? And they might talk about things like, problems they face that week. They might talk about negative thought patterns that they've had. They might talk about situations that happened. And the motivational interviewing approach is really looking for any talk that's kind of positive and change oriented, and recognizing it and giving it a little bit of that reinforcement so that it happens more often. When I say reinforcement, I mean using our attention in a way that encourages that behavior to continue.
Right.
And that's kind of what I borrow from motivational interviewing. So there's 4 steps to motivational interviewing, and I'm blanking a little bit on what those steps are, but the one that I have attached to the most is that just rolling with refusal. If you encounter resistance to change, then seeing it not as a problem to kind of work through and force your way through, but seeing it as the client's just not quite ready yet.
Right.
And let's keep encouraging movements toward being ready. From a behavioral perspective, I see it really as a shaping of language toward positive change.
Yeah, that's what I was just kind of imagining in my mind. We're just trying to get their language to move closer to that change, which in ACT, we think of, at least this is the way I think of ACT, as the language is essentially building our reality. And if I use language that says I can't change, and if I'm in a situation that I don't like, then yeah, my reality is really hard because I'm stuck in it. But if my language starts to slowly shift over and be shaped into, I can change and I can do these things differently, and my situation's going to evolve into this better new way of living, then my reality reflects that. And so that's the way I've been thinking about language for the last several years, just due to ACT.
Yeah.
So I can see what you mean by motivational interviewing.
There's a clear and strong relationship between the brain and our environment, and everybody kind of knows that when things change in our brain, that our behavior changes too, right? So we know that if I take a pill that's going to change my brain chemistry, I'll act different. Or if there's God forbid, there's damage to our brain, it's going to result in changes in behavior. We all kind of know that behavior starts with our brain. But what a lot of people don't know, or often we sort of lose track of, even in the therapeutic process, is that relationship is bidirectional. It goes both ways. When we change our behavior, it actually produces change in our brain as well.
Yes.
And again, thinking of behavior as not just physically what we do, but what we think and what we feel.
For sure. I had a really, really bright supervisor whenever I was in graduate school, and I remember her saying to a set of parents that we were doing therapy with that, if you're ever mad at your husband, then instead of, doing something that suggests you're mad, like not talking or something like that, go out and buy him a coffee and give that coffee to him, because that behavior shows that you love him, you care about him, whatever it might be. And that behavior will tell your brain that you love him, care about him, and it will start to shift you out of the argument or out of the anger from being mad at him. And it's changing the behavior first. You're just making a decision to change your behavior before you feel like changing your behavior. And it's so interesting because I've tried it a few times. Your brain cannot hold that discrepancy. It just can't. It will start to change your emotions if you change your behavior first.
Totally. Yeah.
Yeah.
And so I'll say a little bit about evolutionary science and how our science of behavior is related and kind of brings things together. And this is kind of at the core of what I think clinical behavior analysis is and should be, and should move forward to be. So we all are familiar, I think, probably with evolutionary theory and to some extent natural selection, which is basically individuals within a species have certain variation naturally with certain traits, right? We all vary in height, we all vary in weight, we vary in muscle tone, all of these different things. And natural selection basically says that traits get passed on through our species to the next generation and the next generation over and over again because they help us survive. And so an example of this is if we think about American tree frogs, this is an example I use often. So there's gray tree frogs and there's green tree frogs. Now they're both tree frogs. They're about the same size. They both reproduce in the same way. They lay their eggs in small pools or ponds. They both live in ground vegetation. They both eat insects. And so they're very different, they're very similar. So why is there not just one species of tree frogs? Why is there gray and why is there green? Well, if you look at a map of where these different frogs are laid out, they overlap. But you see more gray tree frogs in Northern America. You see more green tree frogs in Southern America. What you find is that the gray tree frogs tend to live in wooded areas, and they blend in with the dirt and with the tree bark better. And the green tree frogs tend to live in more kind of swampland area and blend in with more of the aquatic vegetation better, right? So that subtle change, that trait, that color has allowed certain frogs to survive more here and other frogs to survive more down here. As a basic example. So the traits that we have natural variability, and the traits that are more helpful for us to survive are selected for by our environment. Our environment picks those traits out and helps us pass those on so that the species is more likely to survive down the road.
Yeah.
This is very similar, at baseline to what behavioral science is. So when we take that concept of selection and look at selection for an individual, we're going about our day and we have random variation in our behavior, in our thinking patterns, in our feeling patterns, and in what we do. Ever since we were born, we have natural variation in our behaviors, and the things that have allowed us to survive in our environment, in our context that we live in, are the things that stick around. And that process is called reinforcement. The things that reinforcement selects for, we keep doing. And so anytime that we see a behavior, including thinking and feeling, that's still happening right now here today, and is happening right in the session room during therapy, that's a behavior that's been reinforced, it's been selected, because it helps that individual survive in the context in which they live. And it's this concept that I think really kind of brings psychology and biology all together in one.
Right.
And it's how I kind of perceive the world, and I think it's a big step kind of moving forward. So I remember being, I don't know if you had this experience, but I remember being in undergraduate psychology classes and even in grad school, and going from psychology class to psychology class and learning all of these different terms and these concepts and these people and all of these things, and kind of being stumped at, like, I don't get how it all goes together. And after I've taken all of these classes in psychology, I still don't get why people do what they do. And I remember being very frustrated by that. And my experience with behavior analysis started to help me kind of bring it all together and understand it through that common scope. And unfortunately, that science has become, narrow in its application. And we've gotten to a point where we're not really thinking in that sort of way when we're dealing with things that are, mental health in nature, depression, anxiety, anger, again. And a lot of therapists have been, I think, therapists who have been trained behaviorally have been frustrated because, you get into an office setting and those are the things that you're working with. Those are the things that people are dealing with in real life. And the behaviorally trained therapists are kind of wondering, like, I don't know how to manage this. So they turn to cognitive approaches. And that's what I did. And so I started trying to implement cognitive behavioral therapy for a while. And I remember thinking that, this just doesn't really, like, I don't really get what I'm doing here. I don't get how this all, like, goes together and fits together. And it took me a while to really just kind of get back to that place where I'm thinking of behavior through that process of selection.
Right.
So when I'm talking to clients and we're talking about things that they're thinking, or things that they're feeling, or things that we're doing, I'm always trying to understand, why is this happening in your world? Why are you selecting those behaviors, and what purpose are they serving? And this is a pretty universal rule that applies to anything that causes us psychological distress. Which of those thoughts and which of those feelings are helpful? And if they're helpful, give them a little bit of your attention, give them your time, give them some of that reinforcement so that they come back. And if they're not helpful, and this is where some of those ACT strategies come into play, the diffusion strategies and mindfulness, how can we let those unhelpful thoughts and feelings and behaviors get out of our way so that we can live a life according to our values?
Yeah, I so agree with you on all of that, for sure. I know whenever I was trained on doing CBT, I never felt like I was really helping clients. And I had someone say to me one time that they felt CBT was condescending. And I thought about it for a minute and I was like, yes, exactly. Like, who am I to say to someone that their thought is illogical or distorted? Like that, like it's
that's so interesting.
Right? Like I hated always saying that to people because if you think about it, their thought is it's being selected based on their environment. Someone with PTSD, they were in an environment where those types of thoughts kept them alive. So it's not, I don't know.
Yeah.
I didn't like it.
Yeah.
I like ACT.
One of the experiences I rubbed up against a lot was when taking a CBT approach, I would ask clients, what is your thought process when you're going through that thing, right? What are you thinking about? And because I work with a lot of kids and teens, they would go, I don't know. Mm-hmm. And then I go, okay, well, let's track your thoughts. Like, let's come up with some thoughts so that we can work on them. And I was never really sure, like, are they just starting to create thoughts that they want me to hear so that we have something to talk about so we can stop sitting in this awkward silence? Or, is the thought even the thing that's most relevant toward their change? Right. And I was having a really hard time connecting with it. And the parents would ask me, why are we spending so much time focusing on the thinking pattern? And I would go, I try to explain it in the best way I could, but I'd go, I don't really know, honestly.
Right.
I'm I'm not always seeing the relevance of it. And so anyway, I you know, did a lot more kind of training for myself in CBT, bought some books, tried to understand the cognitive theory model better, and started to realize that this doesn't actually really align with my theoretical approach, and started to kind of rethink that approach a little bit. Now, a lot of the techniques that I use in a therapy session are very similar to what a CBT-oriented therapist might use. You know, somebody can be CBT and still use components of ACT. They can use motivational interviewing strategies. They can use, you know, behavioral consultation strategies. A lot of the strategies come from the same place, but the way in which we are understanding our clients and kind of thinking about next steps and how we treat those behaviors within the session are a little bit different with the clinical behavior analysis approach.
Right, yeah. And I kind of see it almost as, like, for the cognitive piece at least, I see ACT and CBT as like opposite. And where CBT is saying, you know, transform your thoughts. You have the potential to have this magnificent mental inner world that feels good. I feel like ACT says you really don't have control over that. Your mental inner world is responsive to the stimuli of your environment, and that is to keep you alive and healthy, keep your offspring alive and healthy, and you don't really have control of that. So choose which stimuli or thoughts you're going to pay attention to, and choose them based on your values. Choose them based on the life that you want to have. And that to me makes sense.
Totally. Yeah. And so, like, what the CBT model really is that there's something that happens in our environment, very similar to a behavioral model. And then in the cognitive model, there's something that happens intermediary. It's usually attributed to be automatic thought.
Yeah.
It's an automatic thought that occurs, and that automatic thought then results in simultaneous feeling, behavior, and a physiological response. Mm-hmm. Those things, so there's this kind of mediary step in the middle, this automatic thought, and that's the part that that's different from a behavioral perspective. So those two perspectives are very similar in a lot of ways, but it's that intermediary that's different. And so from a clinical behavior analysis perspective, we see the thought as part of a collection of the behaviors that are produced from that initial environment change, and that the same rules apply to the thought as applied to the feeling and the behavior itself.
Right.
And that part of it for me was really hard to understand because it's difficult to kind of define the parameters around what does that automatic thought look like? Why do some people think certain things and other people think other things? And what's going on with all that? And why do our thoughts do what they do? What are the structures and what are the principles involved there? And then it was very hard for me to wrap my head around until I started thinking, you know, what if the thought isn't the thought just behavior too? And don't we select for our thoughts in the same way that we select all of our other behaviors because they've helped us survive in the environment in which we live? Right. And if we start to think of it that way, our approach becomes a little bit different, where it's not really figuring out what our thoughts are and challenging them and changing the thought in order to impact behavior. It's seeing the thought as part of the collection of behavior that all serves the same purpose. And so we can dive into the thoughts in a different way and say, is the thought helpful to me in meeting my goals, or is it unhelpful? And which thoughts should I select for if I want to meet my goals?
Right. So I know my answer to this. I'm wondering what your answer is to this. It's probably the exact same as mine, but let's see. So I'm wondering, what types of clients do you think are a good fit for clinical behavior analysis? You know, you've mentioned several different approaches within that framework. So for any of the approaches within that framework, which ones are a good fit and which ones might not be a good fit?
Okay, that's a good question. I think that clinical behavior analysis it's going to have to be adapted to the individual client, right? some of the approaches I talked about today, and I'm speaking to like a client who has the language capabilities to really kind of talk about their thinking and their feelings and their behavior, right? And that's not to say that we couldn't use some of these strategies for clients who can't do that, but we would have to adapt them in some ways. So for a client who is limited verbal, you know, the thoughts and the feelings, they're not things that the client's able to really talk about. We might have to rely a little bit more on some of those physiological changes that we see. A client comes in for anxiety and they can't say, I feel anxious right now, or, you know, I'm worried about so-and-so. They're still gonna show it through their behavior, right? They're gonna withdraw, they're gonna look nervous, they're going to present anxiety in some way. There's a reason that other people know anxiety is happening. You know, mom and dad are bringing the client to therapy for anxiety because they see something that looks like anxiety. Yeah. And so there's behavior that we can intervene with in the same way that we would intervene with these other behaviors like thoughts and feelings. And so the theoretical orientation remains the same. The actual techniques that we use might be a little bit different. We're gonna have to tailor things to language that's understandable and relatable for the client. We might be selecting more experiential activities, you know, more direct practice like behavioral skills training, than kind of diving into what are you thinking, what are you feeling right now.
Yeah. Okay.
And so specific clients, I'm not aware of a specific, you know, client group that I don't think that this would be a helpful approach for, because we all have behavior. And like I said, I think that this selection process is what brings us together. It's what brings the whole nature of why we do what we do together. Mm-hmm. And so anybody who's doing stuff, which is all of us, and anybody who has goals for wanting to change, wanting to improve, wanting to live a life more according to their values, you know, it's going to be a good fit for. Yeah. I can say, like, what I tend to see most often, I work with quite a few people on the autism spectrum. I work with a lot of people with ADHD, with learning concerns, depression, anxiety, anger management difficulties, interpersonal difficulties, some, you know, short-term adjustment or grief type cases. So, you know, parents are going through a divorce and kids having a hard time through that process, or somebody close passed away, or, you know, adjusting and working through that. So that's a lot of what I've seen.
Okay. I know we've been going at this for a while. I just have one more question for you. And it's only because you just mentioned that you see quite a few autism patients. Yeah. And so I'm wondering, something that I've noticed is that there's more and more literature coming out for patients with autism who have higher language skills, higher adaptive skills.
Yeah.
The folks who are not going to want to do ABA, and who ABA would just be pretty inappropriate for anyway.
Yes.
So are those the types of clients that you're using this approach with? Yeah,
exactly. And I think that is a need that really needs to be filled. And that's a niche that I'm kind of trying to fill with this service in a lot of ways. Because, well, two things that I'll say about that. One is you have clearly very high functioning people on the spectrum, right? But they still have skill deficits, or they have personal goals, or they have things that they'd like to improve on, and want to be able to see a therapist who understands, you know, what they're going through and their perspective too, right? And just like all of us, right? We all have these things. We all have goals. We all have things that we can better ourselves with. And a lot of those clients are not the best fit for ABA, and are really more of a fit for talk therapy. Right? Mm-hmm. Also, people with autism, there's high comorbidity with other things that are not directly observable. Right, 40% of people with autism also have anxiety, and from what I understand a lot from a lot of adults with autism that I've spoken with is that some of the stereotypical and repetitive behaviors that we see people with autism engage in are to help deal with some of that anxiety and to sort of self-regulate, right? And so high comorbidity with anxiety, with sleep problems, with learning difficulties, with executive functioning, learning, anger management, interpersonal relationship things. How do I engage in small talk with other people, right? That's a skill deficit. That's one that I wish that when I was a kid, I wish that I would have gotten intervention with. How do you small talk with people, right? Because that's still a huge struggle with me. Mm-hmm. How's the weather? Well, I don't really care what the weather is like. How do I just connect with people on kind of a casual conversation level? And these are things that I work with, people in the higher functioning end of the spectrum.
One that I've noticed more recently is the children who were trained on visual schedules and really helping them just to get through daily routines, just so the family and the child can get to school, can get through a morning routine, a nighttime routine, all those kinds of things. I've started to get a lot more feedback from parents that then sets the child up whenever they're a few years older to have pretty rigid behavior or daily routine patterns. And so I've actually been trying to work on using apps with those children to help them have flexibility in their daily routine. Because the visual schedules, it seems like there's this unintended consequence of actually reinforcing rigidity later on. So that's how I've seen it specifically. I don't know, I just think it's interesting.
Totally, yeah, and noticing the functional impact of that rigidity on relationships and getting by in school, and does it contribute to anxiety and all of these other kind of bigger but extremely relevant to quality of life questions. And it's, who do you talk to about that stuff?
Right.
And this is a need, and I think this is one way that's out there to approach it.
For sure. Okay, Dr. Kennert, is there anything else that you would like to share with us? Anything I haven't asked you about?
I don't think so. Thanks everybody for taking the time and watching. If anybody wants to ask me more questions or just chat, I'm happy to do so. You can reach me at B as in boy, 6, KENNERT @gmail.com. That's my personal email address, so feel free to reach out. And you can reach me at Monarch Behavioral Health if you're interested in scheduling appointments or consulting or anything like that as well.
Awesome. I'll put those links in the show notes wherever you're watching this video. And so for everybody out there, make sure you hit subscribe if you're watching on YouTube. And if you're watching this at enildaclinic.com, make sure you sign up for the learning videos to come to your email so that you get all of these amazing expert videos. Dr. Kennert, thank you so much. All of your information, your insights, they are amazing and wonderful. I know I've learned a lot today, and I just really appreciate all of your time. Thank you.
No problem. Thank you.
All right. I'll see you guys next time. Bye.